Good morning. This is Reem Ali with the Health Policy Institute of Ohio. Thank you for joining us at this fourth meeting of the Child Health and Healthcare Advisory Committee. It looks like we have a small group that's joined us this morning, so there might be a few folks that join us later on in the meeting. We have made quite a bit of progress over the past few months, and we're very excited to be at this phase of the project. Just as a reminder, this advisory committee was formed to help inform an assessment of child health and healthcare that HPIO was commissioned to develop by the Ohio Children's Hospital Association. This is work that is being created as a foundation for informing a child-focused policy agenda for the incoming administration. Here is the agenda for our webinar today. We'll be reviewing new data and changes we have made to the priority areas, outcomes, goals, and strategies based on the feedback that we heard a little over a week ago at our last meeting. And we will be going over priority area and policy goal framework, as well as an update to evidence-based strategies. While this is a webinar, we'd like to make it as interactive as possible. I'll be pausing for questions. You can type questions into your chat box. We'll also be doing some polling. And if you have a question, you can also press on the hand icon that you see here on your screen, and this will indicate to us that you would like to be unmuted, and so you'll be able to go ahead and ask your question. If you have trouble hearing or logging on, please feel free to reach out to Alana Clark at Clark Kirk, and her information is here on your screen, and she can help to resolve any issues that you might have. We started this work about 3 months ago in April. Can't believe it's been that long. It seems like it was just yesterday that we started this work, and we really have made quite a bit of progress, and your feedback has been very instrumental to that. The draft assessment will be completed by August 3rd, which is the end of next week, and the final assessment will be submitted to the Children's Hospital Association at the end of August. This is all in preparation for the Vote for Ohio Kids event that will be taking place at the end of September, and Sarah Kincaid from the Children's Hospital Association will talk more about this towards the end of our meeting. In April, we worked on a conceptual framework, and then through May through this month, we've been doing a lot of data gathering, identifying the key findings, and so we are very happy with all of the progress that has been made and your input so far. Now we would like to get some final input to inform our policy framework for today's meeting, focusing on the policy goals and the evidence-based strategies, as well as making sure that we are firm on those priority areas and outcomes. Just to walk you through a progression of our work as a committee, we started with developing a conceptual framework. At the second meeting, we moved on to a review of the data, identifying data gaps, and then at our last meeting, we really got into more detail regarding priority areas and policy goals and strategies. Today, we'd like to get some final input on priority topics, outcomes, and goals, the structure of the priority area and policy goal framework, which you received in your meeting materials yesterday, and the set of evidence-based strategies that we will be highlighting in the assessment. First, I'd like to start with a review of some of the new data that we have received and some of the new data that we've compiled based on our discussions at our last meeting. You all did receive Medicaid data. It's posted on our website as part of the meeting materials, and we just wanted to review that and make sure we had an opportunity to discuss. We had coded the data into common categories to make it easier to see themes. When looking at those categories, what we found was that for ages 0 to 17, when looking at the highest cost conditions for children ages 0 to 17 and 18 to 25 in Ohio Medicaid. So for ages 0 to 17, the highest cost conditions were most often ear, nose, and throat related, followed by mental health and respiratory conditions. For ages 18 to 25, the biggest drivers were around pregnancy and birth-related conditions, as well as mental health and substance use. That other category encompasses a number of other conditions that were different from one another, so they couldn't be grouped together. It includes neurological, gastrointestinal, and respiratory disorders, as well as infections. Here you see the per capita cost for these highest cost conditions, and newborn care, cardiovascular disorders, and neurological disorders, as well as mental health really rise to the top for ages 0 to 17. We see neurological disorders, pregnancy care, and mental health rise to the top for ages 18 to 25. This graphic shows the most common inpatient diagnoses, again, grouped by those categories. And here what is really striking is that we just see pregnancy and birth-related conditions take up kind of most of these categories, followed by mental health. When looking at per capita cost of the most common inpatient conditions, seizure, asthma, and respiratory conditions, and infant care rise to the top. For ages 18 to 25, we see septicemia has the highest per capita cost, followed by mental health and birth-related encounters. Now, for most common emergency department visits, we see ENT, so ear, nose, and throat conditions, again, surface as a common condition. And then the other grouping here includes gastrointestinal disorders, pregnancy care, injury, headache, and oral and dental disorders. And for ages 18 to 25, we really see infections rise to the top. As far as total per capita cost for ED visits, what rises to the top as the highest per capita costs are conditions that are around injury and gastrointestinal issues, as well as respiratory issues, and pregnancy care for ages 18 to 25. We also received data from the Ohio Hospital Association, and we did share that data as well in the meeting materials yesterday. All this data is a little bit more difficult to summarize in a PowerPoint, but we did see many of the same themes that we saw in the Medicaid data. So I just wanted to pause here and see if anybody had any comments or questions or common themes that really stood out to them in the data that they wanted to talk about. If you have any comments on the Medicaid data or the Hospital Association data, you can raise your hand using the hand icon or type your question into the chat box. All right, I don't see any questions or comments, so we will move on. We shared data around motor vehicle crashes at our last advisory committee meeting regarding the breakdown of unintentional injury, and we found that motor vehicle crashes encompass 51% of unintentional injury deaths for ages 1 to 17, and we see it at 29% for ages 18 to 25. If we are looking at specifically at deaths due to injury or violence, motor vehicle crashes rise to top for ages 1 to 17. Now, there was discussion in one of the groups at the last meeting on adding motor vehicle crashes as another priority outcome, but looking into cause of motor vehicle crashes a bit more, we could not find a specific cause of motor vehicle deaths crashes, but did find the data that you see here that young drivers had the highest number of injury crashes in 2017. Now, we still, however, don't have recent data on the specific reason for the crash. So, for example, was it distracted driving or speeding? And we just wanted to make sure that we presented this data to you so that you have a more comprehensive picture of what's going on around motor vehicle crashes, in case that's something that we'd still like to discuss as adding today. There was also some discussion at the last meeting around the substance use measure and potentially adding marijuana or another substance use outcome to the addiction priority area. So here in this graphic, you will see the percent of Ohio adolescents and young adults who used a substance within the past month, broken out by different substances. And alcohol is by far the most commonly used substance for both ages 12 to 17 and 18 to 25. We also see that Ohio performs worse than the US on heavy drinking for young adults, and that means more than 14 drinks a week for men and 7 drinks a week for women. After alcohol, we see higher rates of tobacco and nicotine use, as well as marijuana. It was discussed in the last advisory committee meeting, potentially adding marijuana as an outcome because we are likely to see greater disparities around marijuana use than we might see with alcohol and tobacco use, racial and ethnic disparities specifically. Any questions regarding this data or comments? All right, we will move on to a discussion of teen births and unintended pregnancy. Again, this is something that was discussed at the last advisory committee meeting, whether or not we should keep teen births as a priority outcome. Here is the data around both teen birth rate as well as data around unintended pregnancy. And so there was discussion around removing teen birth rate. And as we dug into strategies, it was rising to the top. Unintended pregnancy was rising to the top as a driver of infant mortality. And so just putting these two outcomes side by side, what we see here is that we have been moving in the right direction on both measures and perform worse than the US on both measures, although our performance on unintended pregnancy is a little bit poorer than that of teen birth rate. Unintended pregnancy is not broken out by age, so this is all women that were reporting becoming pregnant when they never wanted to be pregnant or before they planned to be pregnant for all ages. And this is really seen as a potential driver of infant mortality, whereas teen birth rate is not considered as much of a driver. So if our focus is on infant mortality, we may want to consider unintended pregnancy as an outcome or just removing either. And we'll talk more about that in a bit as well. Any questions or comments on that? And please feel free to use the raise your hand icon or put your comments in the chat box. All right, so we want to move on to a discussion of the priority topic areas and outcomes. We shared with you in the meeting materials a new framework, but I wanted to review what we had discussed in the last advisory committee meeting or what we had heard from advisory group members. There was some discussion around elevating mental health and addiction. So there were several advisory committee members that felt that we really needed to have a stronger focus on mental health and addiction and elevate that somehow in our priority framework. There was a discussion, as I mentioned, around removing teen birth. There was also discussions around removing obesity as an outcome measure under chronic disease. There was, again, that discussion around the addition of motor vehicle crashes. Adding dental care was also something that was discussed in some of the work groups at the last meeting. Adding another substance use measure or adding marijuana use. And the other substance use measure, there was some discussion around the addition of an opiate-related measure. We also heard that that folks needed to see consistency in the inclusion of prevention and treatment across priority areas. So there were some priority areas that had specified treatment and management or prevention, and so there needed to be a little bit more consistency in how those were addressed in the priority area framework, and then clarity around the access to care as a cross-cutting factor. In the new framework that you see here on your screen and that we shared in the meeting materials, we have put mental health and addiction at the top as a way to elevate or direct focus on that priority area in particular. Around the alcohol use outcome, we added heavy drinking as a metric to track. We replaced teen birth with unintended pregnancy, and we'll have more discussion on these in just a bit. Access was removed as a cross-cutting factor on the framework, but instead was incorporated as a policy goal across all priority areas. And when we move to discussion of policy goals, I'll highlight that more. We removed references to prevention and treatment to keep the priority framework clean and emphasized both prevention and access to treatment in the strategies that we proposed highlighting in the assessment. And then we replaced obesity with healthy weight. All right, so moving into the discussion of unintended pregnancy and teen birth rate. What we heard from folks is that maybe removing teen birth rate off of the priority outcomes under maternal and infant health. And so I just wanted to share this data with you again, and we were going to poll you with a question. So given the data that we've presented in our discussions, whether you wanted to replace teen births with unintended pregnancy, keep teen births, or remove teen births and not replace with another outcome. So if we did that, going back to the policy framework, under maternal and infant health, we would still have infant mortality and preterm birth. So again, here are the three options, and I wanted to give you all a chance to discuss this a bit more before we go into live polling around this issue. But we also wanted you to keep in mind the prioritization criteria that we had discussed before around priority areas. So keeping in mind how severe the problem is. So what's the magnitude of the problem for Ohio's children? How does that outcome relate to that as a factor? Also, whether there was alignment with the state health improvement plan and other local priorities, and then also taking into consideration things like whether or not there was going to be an ability to act on this outcome and that was realistic within the policy landscape, that there would be actionable opportunities so that there was already maybe momentum around this issue that was happening in the state that we could align with. And then keeping in mind that we shared secondary data here, but is this something that arose as a priority in the hospital and local health department document review? So was this a hospital or local health department priority? So keeping that all into consideration, we wanted you to think about this question here. So I wanted to open it up to discussion first before we go into the polling. If anybody had any comments on this. So I see Christine says she's very concerned about removing teen births. Christine, we're going to unmute you if you can talk a little bit more about your concern. Oh, your audio pin is not plugged in, Christine. So if you can plug your audio pin in, then we'll be able to discuss this a bit more. Anybody else have thoughts about teen births and removing teen birth? Give folks a chance. And if you have not plugged in your audio pin, then we won't be able to have you unmuted for the discussion. So we have a question around what are interventions to decrease unintended pregnancy? Is it LARCs? And that's from Marissa. Marissa, yes, that is one of the interventions that is highlighted as an evidence-based strategy to decrease unintended pregnancy. So comprehensive access to contraception, including LARCs, is one of those strategies. There are other strategies as well that can be implemented. The ones that we have highlighted related to this particular outcome in the current framework are the expanding LARC access, and that's the primary one that we've highlighted, that the evidence shows strongly works. Any other questions or comments around this? We can just move into polling. You are a quiet bunch. I wake you up this morning. All right, we're going to go ahead and move into polling. So you will see the question pop up on your screen. All right, we're getting responses, just giving you all some time to answer. And when we get a good number of responses, we'll go ahead and share the results. Isn't this all exciting? It's live action. All right. So the majority of you all said to replace teen births with unintended pregnancy. So we're going to go ahead and move forward with that. And we can talk more about the strategy component a little bit later on. All right, so moving to our next question. So there was discussion at the last advisory committee meeting on replacing obesity either with healthy weight or removing obesity completely. Now, we still have physical activity and food insecurity as priority outcomes under chronic disease. So I just wanted to give folks, again, an opportunity thinking about the criteria for outcomes. We do want to keep a concise list of outcomes. How does this play into being actionable under the current policy landscape? Is this an outcome that is important for us to continue to track? Any questions or comments on that? I'm going to go straight into the polling on this one. All right. So you will see this question pop up on your screen, and you can go ahead and pick your response. We see that about 27% have voted. Once we like to hit about 80%. And this is such a small group, we'd really like to see everybody vote on this. We're at 45% now. All right, and again here we do see that the majority is saying replace obesity with healthy weight. So we will move forward with that as well. We have some excitement on that one at HPIO, so that's great. In alignment with our thinking. We are going to move on to the issue of substance use. And so there, again, the advisory committee members at the last advisory committee meeting had some discussion around adding another addiction-related outcome measure. And there was some discussion of marijuana, particularly regarding race, ethnicity disparities for marijuana use. And we do see that marijuana use is the second most commonly used substance among both adolescents and young adults in Ohio. And then there was also some discussion around adding an opiate-related measure. So anybody have thoughts or comments on that, or want to make strong arguments for either making no change to addiction outcomes, adding marijuana, or adding an opiate-related outcome? Go ahead and click on your hand icon if you have a question and we can unmute you, or you can type your question into the chat box if you're like me and have a cold and don't want to speak. All right, I think we're going to go ahead and move into the polling for this question as well. So given the data that we've presented, do you want to make no change to the addiction outcomes? This would mean keeping both alcohol and tobacco use as the addiction outcomes under the mental health and addiction priority area, adding marijuana, or adding an opiate-related outcome. I see the numbers are close, so if you haven't voted, please do vote. We want to make sure that we have good representation across the advisory committee. Oh, wow, we're seeing a lot of fluctuation, so we're going to just give it a little bit more time. Again, keeping in mind that we want to make sure that we have a concise list of outcomes that we have a child-focused population. And so what are the addiction outcomes that are most relevant to a child-focused population? All right, we're going to go ahead and share. Okay, so we see here that adding an opiate, it's pretty close, but adding an opiate-related outcome was the majority for this poll question. So we will move forward with that as well. All right, and then our final poll question is around the addition of motor vehicle crashes. Now, if we are going to add motor vehicle crashes as an outcome, we will have to add another priority area. Motor vehicle crashes also call for a slightly different framing of policy goals and evidence-based strategies than the other priority areas that we have already selected as a committee. So they're going to call for slightly different strategies and slightly different policy goals. It's a different approach to address motor vehicle crashes. So keeping that in mind, anybody have strong feelings about motor vehicle crashes? The question also includes dental care. So do you want to add dental care under chronic disease? So your options are adding motor vehicle under a new priority area of unintentional injury, adding dental care under chronic disease, both option 1 and 2, or keeping things as for chronic disease and not adding unintentional injury. Again, keeping in mind the prioritization criteria and wanting to have a concise list of both priority areas and outcomes. Anybody have strong thoughts on that? Okay, we will move to the polling. Oh, you guys are voting quickly on this one. All right. So what we see is the majority says neither option 1 or 2. It's a pretty even split between dental care and adding both options. So we're going to move forward with we're not going to add motor vehicle death under unintentional injury or add dental care. Okay. So we will make those adjustments to the policy priority area framework for the assessment. And really what we saw that was going to be slightly different from the framework that we shared with you all was the addition of an opiate-related addiction outcome. And here you see the policy priority areas and policy goals. And we've done a number of things in alignment with what we heard from the last advisory committee meeting. So here you'll see the updated policy priority framework outlining the top 3 policy priority areas, along with the outcomes we discussed. And so what you'll see different here is, again, an addition of an opiate-related outcome measure under mental health and addiction. We had heard at the last meeting that folks were having a very hard time connecting the policy goals with the priority area. So we made the connections clearer, and in doing so, we collapsed policy goals so that they could more directly connect with a policy priority area. The policy goals that you see listed, there are 8 policy goals, so we did reach our objective of having 8 actionable policy goals, are that young Ohioans are socially and emotionally healthy, do not use or abuse tobacco, nicotine, or alcohol. We'll have to make an addition around opiates to that one, and then have access to high quality and coordinated behavioral health services. And those policy goals are all related to mental health and addiction. Under chronic disease, the policy goals are that young Ohioans with asthma live in healthy, smoke-free homes, are physically active and eat healthy, and have access to high quality and coordinated health services for asthma and healthy weight management. And then the last policy priority area goal is that around maternal infant health is that Ohioans have access to high quality coordinated pregnancy and infant health services. You'll note that each priority area has a policy goal related to access to high quality and coordinated health services. And this is how we've embedded access to care as a cross-cutting factor. Other policy goals that are not access related are all focused on prevention, which again is something that we heard at the last meeting is really critical to embed. We also have the policy goal that cuts across all priority areas that Ohio families have access to high quality early childhood services. Now, associated with each of these goals, there are evidence-based strategies, and we'll get into a discussion on the strategies as well. But we also highlighted foundations for healthy children. So we heard that there was a need to emphasize equity and make that stronger, and that's what the first foundation is referring to. All young Ohioans have the opportunity to make healthy choices and achieve optimal health, regardless of where they live, their race, ethnicity, or other social, economic, or demographic factors. That all families in Ohio have the opportunity to achieve financial and housing stability. Now, this was actually a policy goal at the last advisory committee meeting, but what we heard is that this is very much more in the social determinants of health world, and this was a foundation for the other policy goals, and so we moved it into the foundations for healthy children. The other two foundations that we've emphasized are that Ohio needs to have strong investments in data collection, research, as well as evaluation of strategies to improve the health of young Ohioans, and that healthcare payments need to incentivize value. So with that, I wanted to see if folks had any comments on the framework. In particular, is there anything from the framework that you think is critical that is not included or is missing? Or is there anything on the framework that should be removed? So we're looking for feedback on how to make the framework stronger, thinking about the audience for this assessment, which is state policymakers, the incoming executive administration. Is there anything that you think is critical on this framework that is missing or anything that should be removed? Again, feel free to use the hand icon if you have a question or comment, or type your comments into the chat box. If you think the framework is perfect, you could let us know too. So it seems like folks are generally in agreement with the framework. We're not seeing any comments or questions or anything being typed in the chat box. So there's nothing that we think is missing from this framework or that needs to be removed from the framework to make it stronger or more clear. And I'm going to put the framework back up for you all, just in case you don't have it in front of you in your materials. Okay. As I mentioned, to help connect the dots between both the priority areas, goals, strategies, and outcomes, we created what we call our master matrix, where we've highlighted the priority area, the policy goal that aligns with the priority area, the strategies that align with the policy goal, the outcomes that the evidence shows are impacted by the strategy, which of those outcomes most closely relate to the priority outcomes that we've identified in our framework, and then the priority metrics that we recommend being tracked to ensure that we are moving the needle on these priority outcomes. I'm going to walk through the strategies that we have included, and I'd like to get some feedback on those strategies to make sure that we are highlighting the right things. Under the policy goal, young Ohioans are socially and emotionally healthy. The evidence really pointed to increasing access to and implementation of universal K-12 school-based prevention programs. And in the last advisory committee meeting, those were listed out as separate strategies, but what we've done is really collapsed these programs here. So that includes school-based suicide, school-based violence prevention programs, PATHs, social emotional learning, and PBIS, school-wide positive behavioral interventions and supports. Under the policy goal number 2, young Ohioans do not use or abuse tobacco, nicotine, or alcohol. We will need to do some tweaking to this policy goal to make sure that we also address opiate-related issues. It will call for likely a slightly different strategy. Under this, we have pricing strategies for tobacco and alcohol products include increasing the unit price for tobacco products and alcohol taxes, mass reach communication campaigns for tobacco, and universal school-based programs around alcohol misuse and impaired driving. Policy goal number 3, you'll see the strategies that are listed there are higher education, financial incentives for health professionals serving underserved areas, school-based health centers, specific to the provision of behavioral health services, and telemedicine or telehealth, again, specific to the provision of behavioral health services. Under policy goal number 4, young Ohioans with asthma live in healthy smoke-free homes. We have home improvement loans and grants, healthy home environmental assessments and home visits to reduce asthma triggers and improve self-management, and improved access to smoking cessation for families and families of children with asthma. And those include things like quitline and other interventions. For policy goal 5, young Ohioans are physically active and eat healthy. We have the expansion of school-based programs to increase physical activity, includes things like active recess, physically active classrooms, enhanced school-based education. Expanding access to school-based breakfast programs is another evidence-based strategy that we have highlighted. Expanding access to green space and parks, and expanding access to healthy food initiatives and food banks. For policy goal number 6, we have expanding access to evidence-based asthma medical management, increasing obesity screening in children, and expanding access to medical homes. For 7, the 2 strategies that are focused around the policy goal of accessing high-quality coordinated pregnancy and infant health services are expanding access to centering pregnancy and then expanding the LARC access. Marissa, to your question earlier, and that particular strategy is specifically related to unintended pregnancy. That last policy goal number 8, that is cross-cutting. The 2 strategies listed there are expanding access to early childhood education and expanding access to early child home visiting programs. So I know that was a lot to go over. We have 21 evidence-based strategies that are listed on the matrix currently. Our goal originally was to get to 16 evidence-based strategies. So my first question is, any strategy on this list that you think should be removed? And we scoured the evidence registries for what the evidence told us works, particularly related to the priority outcomes that we wanted to impact. And these really were the strategies that rose to the top. They were also the ones that folks felt most strongly about at the last advisory committee meeting. So any of these strategies that folks think should be removed from the list? Again, you have your little hand icon. Nobody's used it yet. I hope it's working. Or you can type into the chat box if you have any thoughts on something that could be removed. And our next question is, do you think that there should be a strategy that needs to be added, needs to be an evidence-based strategy that addresses the priority outcomes and aligns with the policy goals that we talked about? And if you can think of a good evidence-based strategy, then what needs to be removed off of the list? So what should it replace? So you can add one on if you can take one off. Marissa, you're asking about talking about centering pregnancy a little bit more. So yes, we can definitely talk more about centering pregnancy. Can we unmute you, Marissa? Are we able to do that? Yep, okay. So we're gonna unmute you now. Marissa?
Hi, thanks. So I'm a personally a big fan of centering pregnancy and know people who have gone through it and have had wonderful results from all walks of life. I have, so I had a client, I don't know, a couple of years ago who had been interested in getting OMAS and ODM to support, different kinds of group counseling payment and or other payment mechanisms for centering pregnancy as a way to spread it across the state, and could not get any traction in our advocacy efforts because they thought it was kind of too targeted and not something that would fit in every community. And I'm not at all an expert in this, so I don't know if that's, I'm sure there's some validity to that in the minds of the people who said it. So I'm just wondering what the group thinks about that and whether or not it should stay here as a policy goal if it is, or if it's too specific.
Anybody have thoughts on that? So this is a specific strategy that would need to be implemented. So there needs to be work on the part of state agencies to help expand access to this particular strategy. That's what highlighting this strategy would mean. Anybody have thoughts on that? And then I have a question around seeing the list of evidence-based strategies. So the evidence-based strategies list is in that master matrix that we sent over yesterday as part of the meeting materials. That matrix is too big to put on the screen, so we don't have it on the screen or on the PowerPoint. But if you go to your meeting materials, the link for meeting materials that was sent out yesterday, it is included in that Excel. Anybody have thoughts on the centering pregnancy? Okay, Teresa, we're going to unmute you. I see that your hand is up.
Good morning. Thanks for all of the work. I really do appreciate the way you put this together. I think it flows really nicely, so I wanted to share that. I have a question around the strategy in Goal 3, which currently is limited to, I'm finding the paper, to school-based health centers. However, if the goal is access to highly coordinated, high-quality services, that is a very narrow target. And the American Academy of Pediatrics since 2004 has identified 3 specific models for increasing access, particularly in schools for young people. And that's really, I think, where I know the incoming administrations are both looking at how do we increase access. And I think what's very limiting if we're saying it's only through school-based health centers.
Okay, so are you talking about things like school-linked health services and?
Yes.
Okay, so
especially for behavioral health. I'll say specifically why. So okay. Just among 36 of my member organizations, and we represent over 150. Just among 36 who responded to a survey, they are in a third of the school buildings across the state of Ohio and 200 districts. And that number is growing by leaps and bounds because schools are looking for more access to mental health services, to prevention services. So we already have partnerships and practices that we can build a foundation on.
Sure.
So it's not just school-based health centers, and I think even in the school health toolkit that was put out by Medicaid and the Department of Ed through the Office of Health Transformation, it was recognizing there's multiple layers of how we get access to services.
Right.
So it's about
so I think you totally,
well.
I think that definitely makes sense. I think why it's listed specifically as school-based health centers here is because that's the wording or terminology that's used out of the evidence registry that rates the evidence in support of. But we can certainly broaden this particular strategy to make sure that it encompasses things like school-linked health services and use kind of a similar framework to what was put out by OHT and ODE as they were talking about expanding school-based health services. Does that get to your?
I think so, as long as it's clear as was when we're saying health services, we're specifically including the behavioral health community
Correct.
Providers as well.
Okay.
Because that was not necessarily included in the health framework And it needs to include all partners because that's actually where many of the behavioral health services are being drawn from.
Okay. Thank you.
Mhm.
We have another question. And the question is from Christine Sanders, in either Policy 1 or Policy Goal 7, are we missing an opportunity to recommend standardized health, inclusive of reproductive health, education standards? Even with removing teen pregnancy as a specific goal, it may fit under unintended pregnancy or emotional health. That is something that the group could consider. I can't off the top of my head think of the evidence rating for health education standards. It is not in there, so it's not part of the evidence registry. So our focus is, if we're going to highlight a set of evidence-based strategies, is focusing on evidence-based strategies or strategies where the evidence is strong. And I know that there is interest in health education standards and work actually that HPIO is a part of around this and work that's going on across the state. I think the other issue is if we're talking about a narrow list of, or a smaller, more concise list of strategies, what is actionable and realistic within the policy landscape. So those are some of the considerations and reasons why health standards are not on the list right now. Other folks have comments or thoughts around including health education standards? And if we include that, is there something that you would like to take off of the list? Okay. I see Sandy Oxley, your hand is up. We're going to unmute you. Sandy? Sandy, are you there? Sandy, we can't hear you. So maybe we can try again in a little bit, or if you can maybe type your comment or question in the chat box. And Marissa, you are saying comprehensive risk reduction sexual education has a high rating. So Marissa, can we unmute you so you can give us more of an context?
I was just doing a little search in the Pew Results First Clearinghouse database.
Okay. Okay.
And they've got that listed with, the green. I can't remember what it is. Highest rated, the program had a positive impact based on the most rigorous evidence.
Okay. Comprehensive risk reduction sexual education.
There might be something more comprehensive than that. I just did a really quick search.
Okay. Yeah. Okay. We will look into that more. Thank you. Thank you for doing the quick search, Marissa. How do other folks feel about that? Is that something that they'd like to see included as a strategy? And do you think that it should replace another strategy that's currently on the list? No strong feelings there? Okay, we can consider that further. Teresa, I see your hand is still up. So I don't know if you have a new question, but we'll unmute you. Just.
Hi, I did raise my hand again. I think, I think it is a good strategy related, what we're talking about in terms of sexual health and education. The challenge, I think, coming back to our criteria about, is it realistic and actionable given the environment that we're working in from a policy perspective? And I think that's a really hard sell. So if I'm being asked to add that and take something else off, even though I believe it and I think it's a good thing, I'm not sure that it's something that is realistic given our current political environment. And even if we, change party leadership at the governor's level, I'm not sure that we're going to have strong enough support anywhere else in the legislature to get that through.
Okay, thanks. Thanks, Teresa. And that is a key criteria for the strategies that we're going to highlight is political feasibility. So I think Teresa's comments are really helpful in just thinking about there are lots of evidence-based strategies that work and that we may feel strongly about, but when we take into consideration just the general political landscape and feasibility, are those the strategies that we'd like to highlight in this assessment? Okay, Marissa, I see you agree with Teresa as well. Any other thoughts or comments? You all have been instrumental in getting us to this point and shaping this list, and I hope that you see your feedbacks and comments from the last meeting reflected in this list. Teresa has another comment, so I'm going to unmute you.
I guess I'm full of comments today.
I love it.
So I have a question around policy goal 8, which is the access to high quality early childhood services.
Yes.
This is one, I've fully supported for a long time. I'm curious as to why, though, in the strategy, we limited it to the evidence-based home visiting program supported by Ohio Help Me Grow. Because federally on the Home V evidence-based registry, and I just looked it up again a few minutes ago, there's about 18 models that are actually recognized as high-quality evidence-based home visiting programs. So, and Ohio has, through Help Me Grow, given some of the financial issues and, other considerations, has a smaller list that they're supporting with the current federal funds. So, but I wouldn't want to limit other payers and other options for use of those evidence-based practices if there's a community that feels there's something they could be doing that might work for them.
Okay. Thanks, Teresa.
So, and I can send you to that it's the HRSA, where I found it was under the HRSA list of home visiting evidence.
That would be really helpful. That would be really helpful if you could send that over. And I know Sandy, we tried to unmute you earlier, so we're going to try again because I think maybe you can speak to that a bit more as well. Sandy, are you there? Oh, darn it. Love technology and hate it all at the same time. Sandy, can you hear us? We cannot hear you, and we have unmuted you. If you haven't put your audio pin in, if you can, that would be great. Okay, so Sandy says, as far as the HRSA strategies are concerned, not all are evidence-based strategies. And so I think that's part of the narrowing likely on the Help Me Grow part. But we can look into that list more closely and make sure we highlight the strategies that are evidence-based. Sandy, did I capture your comment in what I just said? So referring to the HRSA list, not all are evidence-based, some are evidence-based. So as far as the strategies that we highlight in the assessment, we can certainly look to the list and make sure that we're including all of the evidence-based strategies. Okay, some are evidence-informed. Okay. Thanks, Sandy. Sandy's going to share the list. All right, any other thoughts or comments on this list of evidence-based strategies? Some good discussion there that we can do some more follow-up on. Okay, so we will move on to really kind of our final. We talked about the evidence-based strategies. As far as next steps are concerned, so we are going to take the feedback that we heard on our call this morning, as well as the polling results, incorporate those, make the changes that that we all agreed to as far as the poll results are concerned, and dig a little bit deeper on the evidence-based strategies based on your feedback this morning, and incorporate that into the assessment. As I mentioned earlier this morning on the call, the draft is due end of next week. And the final assessment will be complete by the end of August and will be submitted to the Children's Hospital Association. The what's next, there's a lot of what's next. So this assessment really lays the foundation for helping to inform a more child-focused policy agenda for the incoming administration. And that was the purpose of this assessment, and we hope that you will see that in the final product. And there's going to be a lot of work that needs to happen past this assessment. So there'll need to be an advocacy around policy goals and strategies. There's going to need to be actual implementation, and then further evaluation of the strategies and evaluation of impact on the priority outcomes that we are seeing. HPIO's role is focused on that top right quadrant that you see there. So developing this assessment, and Sarah Kincaid from the Children's Hospital Association can talk about next steps and what they envision as next steps on their end. So we're going to try to unmute you now.
Okay.
We can hear you.
Wonderful. Well, I just want to reemphasize how appreciative we are of everyone's time here on this call, and the whole group, all the work that's been put in over the last couple of months. You've really helped shape just an overwhelming amount of data and metrics that are certainly challenging to narrow and prioritize. So over the coming weeks, we're going to be working with HPIO to further mold this work that they've put before you and have it finalized to be unveiled at our Vote for Ohio Kids Leadership Forum that we are having on September 27th here in Columbus. It's going to be at the Convention Center. All of you are invited to attend. It is free to register. The registration will open up sometime next month, and we can get details out to the group once that has been confirmed. We have invited both gubernatorial candidates to participate at that forum and talk about their vision for kids, and we really want to emphasize that prioritizing kids and investing in kids in the state is not a partisan issue, and is really the smart thing to do when we talk about best outcomes for Ohio. So I think as you have a chance to look more at these materials and further digest the work that was put before you, we're certainly always open to your feedback and insight, and we'd love to partner with you further to continue the work. Our goal is after that, after the event on the 27th, to take this and continue to advocate it and push it with our next administration, with the incoming General Assembly, and make sure that Ohio's next budget really reflects these priorities. One of the things that we've talked about is pushing to have a cabinet level position in the next administration that oversees all child initiatives, so that there is that centered leadership position that would allow for hopefully better alignment among all of the departments and agencies when it comes to child pursuits. So I think with that, I will stop there and just say that we hope that as we transition into these next phases, this is something that the larger child advocacy group wants to collaborate on with us. And we're really excited about the potential for what this assessment is laying as a foundation. So thank you all.
Thanks, Sarah. And just any final comments or questions from the group? Well, thank you all very much for your participation. You really have been very instrumental in helping to shape this policy framework and identify the priority areas for this assessment. We are excited to get to work on finishing the draft and then completing the final assessment, and hope that you all are able to see your feedback incorporated in that, and look forward to discussing the results of that with you all when it's released. Thanks again, and have a great day.